Thank you, and thank you for inviting me to hopefully convince everyone that, yes, we're now at a stage where we should be treating high-risk smouldering myeloma. And to do that, I'm going to talk through the following topics. Going to talk about why we actually have the need to treat high-risk smouldering myeloma, what the biological rationale is for the treatment, then what some of the evidence is that we have thus far for treating high-risk smouldering myeloma. We'll consider what expert guidance and guidelines tell us so far, and I think most importantly, what the patient perspective is. So why should we be treating high-risk smouldering myeloma? Well, essentially, if we don't, high-risk smouldering myeloma patients are at high risk of early progression to active myeloma with the resultant risk of end organ damage. There are a number of risk stratification models which can be used now to predict the likelihood of a smouldering myeloma patient transforming to active myeloma. So it's no longer just the days where we'd say it's 10% transformation per year. One of those models is the Mayo 2220 model, which looks at tumour bulk. So that's paraprotein level, light chain ratio, and bone marrow percentage, scoring a point for any of those being over 20. The IMWG model takes that and adds in high-risk cytogenetics as well. So if we look towards the table at the bottom, those patients that are intermediate risk score 2 out of 4. Those that are high risk are scoring 3 or 4 out of 4. And respectively, they have a 46 and 63% chance of progressing to active myeloma and probable end organ damage at 2 years. So I would propose that rather than wait for that to happen, we should be intervening early to try and prevent it from happening. Now, I appreciate a counter-argument could be that we can just monitor these patients closely and try and act before end organ damage occurs. But actually, there's some evidence that observation alone may be insufficient to prevent end organ damage. This is some real-world data from the Mayo Clinic, where they serially followed a number of high-risk patients via the 2220 model. And the median time between appointments was 3 monthly, which I think is probably quite standard for what we all do. The median time to progression to active myeloma was around 2.5 years. And despite this quite close monitoring, almost half the patients presented with a clinically significant myeloma-defining event. And by that, I mean either hypercalcemia, renal insufficiency, or bone lesions. There's also some evidence that high-risk smouldering myeloma is associated with reduced overall survival. This is some data from the Czech Registry of Monoclonal Gammopathies, which is actually one of the biggest European databases for monoclonal gammopathies. And they've got serial long-term follow-up of their smouldering myeloma patients. And they divided them into 2 cohorts, either high-risk or non-high-risk, again using the Mayo 2220 model. As you can see there, the overall survival was significantly inferior for those that were high risk. So again, I'd put it to you that now is the time we should be planning to act early to try and improve this poor prognostic outcome for the high-risk group. Now, there are those who don't want to treat high-risk smouldering myeloma, and one of the arguments may be that we shouldn't treat because there's no conclusive evidence of benefit. I'd counter that with a couple of arguments. Firstly, no evidence of benefit doesn't necessarily mean that there's evidence that there's no benefit. It might just mean that the right trial's not yet been conducted or reported. But also, what does evidence of benefit look like? Prolonged PFS, reduced organ damage, improved overall survival, because there are trials in smouldering myeloma that have read out so far that have showed benefits for those metrics. And I think prolonged PFS is sometimes considered maybe not the most important readout in smouldering myeloma. But as Jan pointed out in the last question session, it's quite a conveyor belt now of myeloma treatment for active myeloma. And when patients start on that, it's quite hard to have a treatment-free interval. So if we can significantly delay the time until then by giving fixed duration therapy for high-risk smouldering myeloma, then I think that would be beneficial to patients also. Another counter-argument I hear is that we shouldn't treat smouldering myeloma because we don't have a standard of care currently. Well, I think that's on us. We need to establish the standard of care. We need well-designed clinical trials. We need to consider the biological rationale when designing the trials. We need to select appropriate endpoints, and we need to consider both efficacy and, I think very importantly in this patient cohort, we need to consider tolerance of treatment as well. we move on to the biological rationale and just the biology of smouldering myeloma in general, just stop for a moment and we'll think about what are the pathways that lead to transformation to active myeloma from smouldering myeloma. And it can be at least threefold. You can get increase in tumour bulk, you can get increased complexity of genomic aberrations, and you can get reduced immune fitness, which can lead to a reduction in how well the immune microenvironment controls the malignant clone. So if we take that forward and think about the biological rationale for treating smouldering myeloma, treating early should mean that there are less genomic complexity, and we're treating before aggressive subclones have grown out. We're treating when there's a fitter immune system, so we would therefore hypothesize that the immunomodulatory therapy should have greater efficacy used earlier when the immune system is fitter. So that means that we're not just moving the treatment threshold forward from CRAB to slim CRAB to smouldering myeloma, but there's a clear biological rationale as to why giving immunomodulatory therapy in the smouldering setting should give us a greater return for that treatment investment. The patients, by definition, should not have end organ damage, so they should have a higher performance status and tolerate therapy better, and hopefully with fewer adverse events. And putting all this together, we may be able to achieve long-term survival, even if we're not eradicating the malignant clone completely. And there's some clinical data to back up that theory. So if we consider the ECOG study, which was lenalidomide monotherapy compared to observation, the lenalidomide monotherapy was given for a median of 23 cycles, then the outcome of this told us that deep remissions may not necessarily be required to improve outcome in smouldering myeloma. If I could ask you to look at the survival curve on the right, what we have there is progression to active myeloma. And you can see that patients that were treated with lenalidomide had significantly prolonged times until they transformed to active myeloma compared to observation alone. And if you then look at the hazard ratio at the bottom of the slide, you can see a hazard ratio of 0.09 in the Mayo high-risk 22-20 group, suggesting that those that derive the greatest benefit from early intervention are the high-risk smouldering myeloma group. But it's also interesting to look at the response rates on the left-hand side. The overall response rate was a fairly modest 54.5%, with not very deep responses. The majority were partial responses. And from this, I think we could infer that preventing CRAB features in smouldering myeloma is driven not only through response, but also through immunomodulation, which is backing up what we saw in the biological slides previously. On top of this, there's evidence that lenalidomide and dexamethasone can improve not only time to progression, but also overall survival compared to observation in high-risk smouldering myeloma. This is some data from the Curadex trial, and I draw your attention to the overall survival curve on the right, where the median overall survival for patients who were observed was 8.5 years. Those that were treated with lenalidomide and dexamethasone, the median overall survival is not reached, and that's a significant difference. So again, a counter-argument I sometimes hear to treating smouldering myeloma is the concern that it will induce clonal progression and lead to emergence of more resistant disease. Well, if we go back to the Curadex trial, then there's evidence that that is not the case. Early treatment with lenalidomide did not induce more resistant relapses. So we can see here that this is a survival curve from the time that each patient progressed to active myeloma. And for both arms, there was no significant difference. In fact, there appears to be a slight trend for patients doing better from that time point onwards if they'd previously been treated with lenalidomide and dexamethasone, median 6.4 years compared to 4.5 years. And it's also worth highlighting that the rescue treatments used were evenly matched in both arms. What does expert guidance tell us to do? Well, we can look at EMN consensus statement, EHA guidelines, BSH good practice papers. There's also NCCN guidelines in the States, and they all suggest that we should be entering patients into clinical trials if they have high-risk smouldering myeloma. And finally, what do patients think about this, which I think is a real key aspect. So I think it's important that we don't underestimate the impact that watch and wait or watch and worry can have on patients. There is evidence that the psychological aspect and the anxiety that patients can feel is equal in smouldering myeloma compared to active myeloma. And I think there will be a cohort of patients who want to take back control and want to have their condition treated early. And we have evidence to back that up from the preference study, which was run in America. In this study, the investigators looked at almost 300 patients with precursor disease, and they asked them how much weighting they would put on 4 specific attributes. And that's preventing myeloma, the cost of treating myeloma, the inconvenience of treatment, and the risk of long-term side effects. And they found that there were 3 different profiles which most patients fitted into one of them. There were patients who predominantly valued the avoidance of side effects. There were patients who were concerned about keeping the cost of treatment low, which fortunately we don't have to worry about in the UK. But there were patients who valued prevention of multiple myeloma above other attributes. And there was a similar split between those that wanted to avoid side effects versus those that wanted to prevent progression of myeloma. So as I said before, I think there will be a cohort of patients that want to be treated early. So putting all these arguments together, I believe that treating myeloma is actually a potential model for how we should be using cancer therapy. If we think of early diagnosis and treatment, maximizing efficacy whilst minimizing toxicity, reducing morbidity, having a patient-centered approach with shared decision-making, all of those aspects can be covered if we intervene and treat high-risk smoldering myeloma. So, in the context of treating in a clinical trial, and after a shared decision-making process with the patient, I believe that yes, we should be treating high-risk smoldering myeloma. Thank you.